Thank you very, very, very much. So I have a disclosure, and I just want to tell you that I want to promote independent cleft and craniofacial teams and surgeons. See, I had it surgeons and then teams in the Middle East. So my mother is Palestinian. She's from Tulkarm. For the past 10 years, every maybe May and November, I go and operate. So I've operated in Jenin, Nablus, Tulkarm, Qalqilia, Ramallah, Jericho, Hebron, Jerusalem, Bethlehem. So I've operated all over the West Bank. And, no, I was saving the best for last. So this is the cherry. So that's the dessert, but the cherry has been working for the last 3 years, operating on difficult cases with surgeons at Rambam. So, how many of you are surgeons? So this is for you, okay? How many of you are young surgeons? Young surgeons. Okay, now, most of the young surgeons... No, listen, anyone younger than 95? No, yeah, okay. So listen to this. My challenge to the surgeons, but it's also true for speech, it's true for audiology, for orthodontics, for dentistry. Demand the best on behalf of your patient. Do not be afraid to say that you love your patients. We men, surgeons, I think we get embarrassed. We don't say that. But you know what? Love your patients relentlessly. Relentlessly means always to the best. Demand, don't just ask, demand the best from yourself. Get better. For plastic surgeons, for oral surgeons, when you're doing surgery, take pictures. Take good pictures. Some of my pictures you'll see are not good pictures. So I apologize before. Then follow your patients. You know, there's an argument, is this technique the best? Is this technique the best? Is that technique the best? You see, we can say this, but if you don't see your patients at 5, 10, 15 years afterwards, maybe you don't know. Maybe. So think about that. Share and discuss your results. I think that surgeons need friends to talk to about their surgery. Someone where you can say, do you like this? Is this good? Is this bad? That will honestly tell you, no, that's not good. We need to talk. Be the best at getting better, and that actually is the motto at Cincinnati Children's Hospital. Be the best at getting better. And the goal for our patients in the end, speech, orthodontia, is normalcy. You see, if we forget that, then we accept something that's less. And we need to give our patients the very best. I'm talking about poor resources. Remember the title? Optimizing cleft lip outcomes in resource-poor conditions. So sometimes the resource-poor conditions can be at UNC. They can be at big centers. Maybe you don't have someone that provides nasoalveolar molding. You have patients that are not educated. So look at this. So a center that has no team is a poor resource place. Oh, and actually, let me just go back to this. Omri said earlier that there is no Israeli Cleft Society. So just officially, there is now an Israeli Cleft Society, and you are the people. What else constitute or make poor resources? Practitioners that don't know all of the techniques or don't know all of the current information. Maybe not enough cases. Poor follow-up after surgery. So if I do the surgery and I think, but I don't see the patient a month later, 6 months later, 2 years later, when they have a problem and they're trying to call, I need to see them. Poor education for the family and the patient. Absent knowledge of techniques. Lack of materials. So I always use nasal stents after surgery, but there are many places where I go where we don't have nasal stents. I don't have all the resources that I think I need. Sometimes when we're working overseas, we don't have all the sutures that we usually use. Maybe we don't have the dressings, and then sometimes there are poor facilities. But in the end, it's me. If I can't blame the poor facility. I can't blame the family. It's my responsibility. In plastic surgery of the face, there is a group that are like mathematicians. They measure 1 millimeter here, 2 millimeters there, and then you cut to the left, then you cut to the right, 4 millimeters. There are others that are artists, and you've seen this. And so in the end, I think it's a combination. It's both. So when you see this child, you need to be thinking ahead as both a mathematician, careful math, and careful art, careful artistry. One lesson always comes from older patients. So this is not a patient that I operated on, but when you look at an older patient, you see all the things that you do not want to do, that you want to avoid, that you want to get better at. And so in this patient, he's got a problem with the nose. There's some asymmetry at the high point of the left Cupid's bow, but you don't want to do that. You want to avoid that. And so the technique that I've used with some modification is the Millard technique. Most of the techniques that have been discussed today, they start with the Millard, modification, more modification, more modification, so that even cutting would say that his technique is a modification of the Millard technique, the molar modification of the Millard technique. But in the end, I actually agree with Lior. There is no golden technique. There is a golden surgeon. And so what you do is you take one technique, any one, and you become better and better and better. So the markings are, this is the math. For many of you, you've never been in the operating room, but we take calipers and we measure 4 millimeters, 4 millimeters, 2 millimeters, 5 millimeters. And these measurements are what give us the chance to create a normal looking baby. And so one thing that no one has presented that I want to say something about is this. So this is my disclosure also. Only once have I used a lip adhesion. So I know in Soroka, that's routine. But I was thinking to myself again, now why do we not use lip adhesions? And it's because of this incision that we make. This is on the inside. It's at the junction of the gingiva and oral mucosa. We make it. Medial to Stenson's duct, we go up. And what that does is it lets us move tissue for all bilaterals, for all unilaterals. So I've never had to use a lip adhesion. Do I think lip adhesions are bad? No. It's okay. You perfect that technique. So here are the markings, and here's a case. So someone else said, very, very honestly, I'm only going to show you good pictures. So most of my pictures will be good, okay? Here's another one. There are many of you here that would insist that this patient get nasoalveolar molding. Now, at our center at UNC, there was no nasoalveolar molding. And so a very wide unilateral cleft is maybe a place where you should consider, or you could consider, nasoalveolar molding. And so here's this child, maybe a year afterwards. Here's another child. So even in this one, how many of you that do nasoalveolar molding would use nasoalveolar molding in this one? Okay, so the people that do it, I think, would use this. But we had no choice. So this is a resource-poor situation. And so we did the surgery, and this is the outcome. There's a little bit of asymmetry, but very, very importantly, I saw this child again at 8 years old to do the bone graft. And I said to the mother, we haven't seen you in 8 years. Where have you been? She She said, you told me to come back when he was 8 years old for the bone graft. So she listened to me, but not one visit. So they came back once after surgery, and they didn't come back for 8 years, and then they came back for the bone graft. Now, we operate in the West Bank, and here, resource poor, we try to bring things with us, but you need to realize, see how big that tube is? Now, we used an LMA for this child. We did the surgery safely, but it wouldn't have been our first choice for how to do this case. But the anesthesiologist was Ayman did this case with us. It's a friend of people at Rambam. Here's another child. Now this time we had the oral ray tube, everything's good. In this case, we could have and should have maybe used nasoalveolar molding, but when you go to Ethiopia, if you go to China and you see the patient, you have no choice. You can't say, no, wait, come back in 6 months after finishing. The reality in many parts of the world is there is no nasoalveolar molding, and you have to take what you have and be the best with what you can give the patient. So here's a patient, because the history of nasoalveolar molding, you know. This now is at UNC, and so who is it that provided our nasoalveolar molding at UNC? It's Pedro Santiago. Some of you know him very well. Some of you trained with him. Yes. Yeah, exactly. The Pedro Santiago. But so this patient, we wanted to use nasoalveolar molding, but he had feeding difficulties, major feeding difficulties. Now, to me, the one thing that people that love nasoalveolar molding don't admit completely is how much stress it can put on the families. Every week. And so I think it's worth it. But for some families, the stress is too much. But we had Pedro Santiago, and we couldn't do it because this kid was in the ICU 2 weeks, and then again 3 weeks later, no breathing problems, but just feeding problems. He would not feed. He got a feeding tube, but the family just said, no, we don't want to do nasoalveolar molding. So we started, but we couldn't complete. So here's this child, and there he is after surgery. Now, I'm going to suggest to you that if the surgeon puts a little bit more burden on his shoulders, you don't have to have nasoalveolar molding. I think it does make it easier, but you don't have to have it. Especially if you don't have it. Do you see what I'm saying? If you complain to God that you don't have nasoalveolar molding, God may not help you very much there because you don't have it. And so here's this kid, happy. Now I'm going to talk a little bit about bilaterals. And remember, much of what we owe to cleft surgery comes from Millard. And he said, it's twice as difficult with results that are half as good. But you know what? Listen, if he said that, then that's a challenge to each one of us. Let's hold ourselves to the highest standard, especially with bilaterals. You know that there are many different types of bilateral clefts. Incomplete, complete. This actually here, with the hypoplastic premaxilla, maybe the patient that you were presenting from Ethiopia, very small premaxilla, and it literally disappeared. A little bit of stripping of the mucosa and blood supply was gone. But no two bilaterals are the same. Remember, I showed you the older patient? These are the things you don't want to do. So here, a flattened nasal tip, very wide. This is a case that was done in Mexico, and we saw the child. This is the first time we see this child. So there's some problems here. And the philtral column is way too wide. Someone else earlier was talking about a Whistler deformity. This is what he has. There's separation of the muscle. Some major problems with the nose and actually with scar tissue. So here's the technique, and actually I will say that, I've modified the Mulliken technique, so many of you either know him, trained with him, and so it's very aggressive on the nose and takes care of the lip. You have to put the muscle together, and this is why everyone is worried about the premaxillary segment. If it comes too high, it's very difficult to put the muscle there. But I can say this, that the reason we can do this is because of these releasing incisions. I've never been able not to close a de novo cleft. Now, so for some of you, that's very hard to believe, but that's okay. We do trim the soft triangles. I know that that actually is, for many, many surgeons, it's poison, it's wrong, it's bad, it's terrible, but we do it, and I'll show you some results. Someone was presenting the Tajima technique, with the sutures that came out at the dorsum of the nose. You can actually put them anywhere you want. And sometimes overseas, I will use these because it's a powerful technique. It will get the lower lateral cartilage into position. You can do it for one-sided clefts or both-sided clefts, but mostly I don't do this anymore. Here are the markings again. This is the intraoperative picture. And remember that the releasing incisions are here and then up, medial to the Stensen's duct. This is what they look like at the end. You can see the suturing around the nasal margin and the rim. It looks scalloped, but it takes care of itself, and I'll show you some pictures now. So here's one baby, and this is maybe 2 months afterwards, so this is actually quite fresh. Here's another child that we were doing when there was no nasoalveolar molding, and I want you to see what taping can do. Taping's very inexpensive. So look at this. So look at what the taping has done. It's centralized and retroclined the premaxilla, and this kid's ready for surgery. Here's what she looks like in surgery. This rides high now, but it always comes down. There she is, and there's a picture. So now this is no nasoalveolar molding, no breaking of no K-wires in the premaxilla. Actually, that scares plastic surgeons a lot more than it scares oral surgeons. Correct? It does. Okay. For families, because you can't show the full face, what I've done is I've prepared these cuts. So I will actually show families these pictures because they can't recognize who the baby is in this picture. And they appreciate it. I'll actually email them pictures from before. If they say, show me a picture, I'll show them a picture. But they can't see who the patient is. Here's another patient. Another patient. In the States, education can be the most difficult sometimes with either poor families or minority families. But I never want to blame them for not understanding. I will always blame myself. I didn't explain it well enough. So this is a patient also from Mexico, or the family is from Mexico. These are twins. This is no nasoalveolar molding. They're a bit older. The nose is a bit flat, so he's going to need rhinoplasty at some point. There's his brother. And see, listen, the problem is that when they're babies, they're cute. When they grow up, this is why you need to see pictures later. These kids are not so cute anymore. They're fat teenagers is what they are. This patient's mother was put in jail, and the grandmother took the child. Grandmother had health problems, and then an aunt took custody, And so this child had 3 mothers within the first 3 years of life. The test of time, this is still no nasoalveolar molding. And what I want to suggest, so this kid, this is a stable surgical procedure. You see, so now when a resident says, that was great, the best thing I've ever done, and I will say to them, no, we need to wait. We need to wait a year. We need to wait 3 years. We need to wait 5 years. Because the goal is to not have to do surgery at 4, 5, 6, 7, 8. So all of these older patients have not had a repeat surgery. They've been one surgery, 3 to 6 months of age only, finished. And if you look at the data, some of the best protocols are the ones where you operate on the lip and the nose at 3 to 6 months of age. You don't do anything until 17 years of age. Now, you don't want to leave them crippled, but you want a nice result. And that nice result stays as they grow up. So this is a patient, and you can look at the, so this is Pedro Santiago's work. Okay? So this is what he was doing. And so this is a patient who underwent nasoalveolar molding. In surgery, we use the same technique, and it is a bit easier. So I would say, when should you use nasoalveolar molding, in my idea? Wide one-sided clefts and many bilateral clefts, because it lengthens the columella. And what you're doing is you're trying to avoid repeat surgery. So that's the bad picture. It's fuzzy. Sorry. But there she is. But this is also, we did this surgery just before I moved from UNC, so I don't have any further pictures. Sometimes this patient comes to you. The premaxilla is like this, and the patient's 2, 3 years old. We see many, many adopted patients in America. And so you have to do something. You can't do nasoalveolar molding in a 2, 3-year-old. I don't want to break the premaxilla. So you have to close the cleft. Some later cases. So I showed you this one earlier, and you can see the problems here, and mostly taken care of. The nose is better. You need to see the patient again. He's still going to need a rhinoplasty, but his lip fullness is good. Not only do we see this patient, but we see his mother. His mother has a repair from Mexico, Honduras, many, many, many years ago, and we did a similar situation for her. We actually did this this July, and so I don't have strong follow-up procedures, but she also got a tongue flap. And so you can see that the fullness is better, this is better. She had a lot of scar tissue. Another Asian adopted patient. Patients that some of you will recognize from the north, twins, using some of the same techniques. This is a collection of some of those bilaterals. So here, if you are in a resource-poor place, what needs to be done to resource enrich? You create teams. You build knowledgeable practitioners. You take care of the insufficient cases. You improve follow-up after surgery. You educate families. You teach techniques. You provide materials. You improve facilities. Okay.